Assalamu alaikum. Welcome everyone on board. We started our uh, discussion with reference to MCQs based learning and the way we should approach and target learning through MCQs. Okay, so this is our third session in this regard. So I will just quickly have few words that whenever we are reading MCQs, usual approach is that we are only looking for the answer, but actually that is not sufficient. And if you really want to use this way of learning as an excellent tool to clear your concepts and do the things in the right way, you should not only try to find the answer, but at the same time you should try to gather the knowledge which is around and around. Okay, so if you do in that way, your learning will be much better than if you are only trying to find the queen. The queen means the answer. Okay, because that will give you only a tunnel vision, and that's wrong. So because in some parts of world, the training is of such a standard, like if I say the places where only MCQs based pattern is there is US, for example, but their training system is so advanced that actually does not hamper at all, and they have like they are doing it. But in our part of world where we are lacking in a lot of aspects, it's never a good idea only to target MCQs. So we will just continue the same way which we started in our last two sessions. Okay, so just a second, please. Okay, so with this question is on a 64-year-old man. So right now you should just be thinking what are the changes, what are the effects, and how the old age changes our anesthesia management. So this is first point you should be thinking. Then, which the patient has no previous cardiac or respiratory morbidity, is attending for his second treatment for ECT. So the question is around ECT. So what is ECT? Can someone tell? What is ACT? What is ECT? What's the rationale of ECT? Anyone, please?
Sir, basically, it is an electroconvulsive therapy used especially in the severe cases of psychiatric disorder or severe depression, just like to reset the brain. Uh, Electric current or some modulation is given to the
Okay.
brain so that the induced seizure can be occur at that part of a brain.
Okay, so it is causing some neurotransmitter release. Am I right?
Yes, sir.
So that is the concept of electroconvulsive therapy. So the question which they have asked is with reference to that thing. So we should be knowing what are different challenges which we have for electroconvulsive therapy. Okay. So after his previous treatment, he had SVT. So now, if you want to understand this question, let me open some of the source for this. Just a second, please. Can anyone recall the steps of electroconvulsive therapy? Like when initially there is a parasympathetic response or sympathetic response.
Parasympathetic,
Okay. And then after that,
then sympathetic.
okay. So how to handle these two steps? Yes. Just a second. So brief parasympathetic lasts for 10 to 15 seconds, which leads to bradycardia, hypotension, and even asystole. Sustained sympathetic response, peaking at 3 to 5 minutes, associated with release of catecholamines. So that is the basis of this question. Why it is important to just recall that if you want to understand the concept of this topic, you should be recalling this thing. Okay. So with a peak blood pressure of 200 to 1 by 5. So it was not hemodynamically unstable. It was a stable SVT. Okay. Which resolved spontaneously within 5 minutes. For his anesthetic, he had received propofol 90 milligram and saxamethonium 40 milligram. Can someone tell me why we need to give saxamethonium? What is the rationale of giving saxamethonium in ECT? Yes.
Muscle relaxation.
Actually, not really muscle relaxation. Why they want muscle relaxation? They don't want muscle relaxation. The purpose is to prevent injuries. Okay. Because whenever there is fits, there may be dislocation of joints, there may be injury, even patient can fall down, there is injury to the tongue, injury to the spine, there may be fractures. Okay. So the purpose of giving saxamethonium is to prevent that thing. Okay. There is an alternative to saxamethonium with a non-depolarizing muscle relaxant. Can someone recall that medication? It's not available now frequently. I'm not sure where. Maybe in some part of the world it is there. Can anyone recall?
Rocuronium.
No, not at all. Rocuronium is intermediate acting. Yes, Sayyid Ali, you know.
Yes, sir. Mevacuronium.
Mevacurium. Okay. So
Mevacuronium.
mevacurium is short acting. So that is just a brain exercise. So in this text, we have to recall what is electroconvulsive therapy, what are the indication of electroconvulsive therapy, what is the rationale of electroconvulsive therapy, what happens to the body during the electroconvulsive therapy. We will just have a look at it. And this way you can just recall. And then another thing, what is SVT? What is difference between SVT and VT? Yes. What is difference between SVT and VT?
Sir, SVT is basically the tachycardia which is originated from above the nodes, usually is nodal in origin, and VT is basically ventricular tachycardia. So SVT is usually without P wave, and there is an heart rate usually more than 150. And in VT, basically there are three scenarios: with pulse, without pulse, and pulseless activity can be act as VT.
The you have told in a very nice way, but you have missed some very important thing. That is, SVT is narrow complex, and
Narrow complex. Yeah.
VT is broad complex.
Word
Okay.
complex.
Broad complex tachycardia.
SVT is usually like not in different shapes, but VT is maybe monomorphic, maybe polymorphic. Can someone just tell me the name of the polymorphic VT? One of the polymorphic VT, very famous, very interesting name.
So,
Yes, sir.
toss the
Dorsal
points.
three points.
Yeah. So what is the treatment of torsade de pointes?
Magnesium.
Very good. If torsade de pointes does not resolve, it can lead to
VFib.
what is the treatment of VFib?
Uh, Electrical cardioverter.
Defibrillation.
CPR,
The
immediate CPR and then shock.
not immediate CPR, my dear, defibrillation. Okay. If someone
Defibrillation.
is if asking if the patient has witness VT, sorry, this VFib, the treatment is defibrillate. Even Mr. Bean knows about it. Okay. If you must have seen the Mr. Bean movie. Mr. Bean was ready to defibrillate. Okay. So that is just a brain exercise. So whenever you are reading any text, being if you want to understand what is the concept If you do like this, believe me, you will revise in one MCQ so many things in your mind, and it is all mind exercise. Okay. Okay. So now what is the most appropriate course of action for this second treatment? Perform procedure with defibrillation pads on his chest. Premedicate with oral atenolol. Use intravenous esmolol. By the way, what is atenolol?
Beta blocker.
Okay. What is esmolol? What is difference between atenolol and esmolol?
Asmolol is short acting.
Okay. And atenolol is relatively long acting. Okay. So okay. So use remifentanil infusion during procedure. Use sublingual nifedipine during procedure. So actually, the thing is that all these things can be done. But now we have to find, because in some question they will write what is the next step to do. The answer will be different. What is the most appropriate course of action? This is answer is different. Okay. So you just have to identify what they are asking. So let's see what is the answer. What is remifentanil?
Opioid.
Ultra short acting opioid.
Okay, so remifentanil causes tachycardia or bradycardia?
Bradycardia.
Bradycardia.
Okay. So let's see what they have written, on the basis of which thing they are saying this thing. Okay. So they are saying esmolol. So during electroconvulsive therapy, an electric current is applied to the brain via transcutaneous electrodes to induce generalized therapeutic seizure lasting between 10 to 120 seconds. There is biphasic physiological response. The seizure causes an immediate direct stimulation of vagal parasympathetic outflow, which can lead to transient bradycardia. Okay, hypotension and rarely asystole. Can you just recall what can be other parasympathetic effects, or what are other common parasympathetic effects other than bradycardia?
Salivation.
Bronchoconstriction.
Or you went to the transport.
No,
Sorry.
waiting for the other issue. Who's not ready for the summer product?
Okay. Secretions.
He does secret.
Sorry, again, please.
Salivation. Rhinorrhea.
Actually, if so many people will speak together, I will not understand. Yes, Nuseba, please speak out. You were saying something.
I was also saying secretions. आपने कह दिया था.
Okay. Okay. So, okay, pre-medication with an anticholinergic agent is often used to attenuate this effect. This is followed by so what anticholinergic agent will be used to attenuate this bradycardia?
Injection glycopyrrolate. 0.2 mg IV.
Okay. So, like, why not atropine?
It crosses blood-brain barrier, and it may we cannot differentiate after the effects of the electricity and the if atropine crosses the BBB.
This is yes, this is another reason, but actually, the thing is that we just need a
Short
slightly
acting, sir.
sustained. Sorry.
Sir, it is short acting relatively.
Yes, it is relatively short acting, and actually, like it has some, it can have some central effects, and actually, you don't need sudden tachycardia. You just want to prevent bradycardia. So, glycopyrrolate is more appropriate. Okay. This is so for catecholamine mediated, which peaks 3 to 5 minutes after therapy, causing a tachycardia and hypertension, and may give rise to tachyarrhythmias. This sympathetic response can be attenuated using a variety of agents. Beta blocker have been shown to be most effective in controlling both heart rate and mean arterial pressure. Due to the risk of initial bradycardia, such short-acting agents such as esmolol or labetalol given just prior or during the procedure may avoid accentuating the parasympathetic response. So if you have given orally before, the parasympathetic response can be more pronounced and it can lead to even cardiac arrest. That is one of the reason. Okay. So esmolol is preferred as it reduces the peak systolic blood pressure more than labetalol, while labetalol may be associated with a short seizure duration. So this is another important point. Calcium channel blocker can also be effective to control arterial pressure, but reflex tachycardia may occur with nifedipine. Okay. So remifentanil has been shown to reduce both the heart rate and blood pressure and does not have an effect on seizure duration, though use of an infusion may not be available or suitable for these short procedures. Mm, Actually, in my opinion, a number of things can be given, but esmolol is more precise and more controlled. So after initial bradycardia, they can start, its effect will come immediately. That is why they have chosen uh, this medication, because beta blocker they have to choose. So among the beta blocker, because they either this is oral atenolol or esmolol. So first of all, we have to decide. Remifentanil can causes bradycardia, but it is not that much appropriate to prevent such sudden and acute response. And then nifedipine can cause also reflex tachycardia. So these medication remain out. This is actually for treatment if it occurs. So it is not the prevention. So defibrillation is the treatment. So that's why defibrillation is gone. And oral atenolol, again, not a good idea. It can cause exaggerated parasympathetic response. So that's why in these options, the best option is Esplor. Bilal, any point you want to raise on this particular point, the question? Okay, no problem. Take your time. Okay, so okay, so that's let's have a look on some other points with reference to ECT, so that our this topic will also be covered. Actually, if the people are not familiar to these tutorials, I will highly recommend you to read these tutorials because they are very compact and very easy, not like the books in which things are dispersed and you don't get the topic covered in such a nice way. Okay, so this is with reference to the indications. You can have a look. Okay, acute life-threatening depression, drug-resistant depression. Okay, catatonia, where first-line treatment with intramuscular. What is catatonia? I don't remember. Can anyone know what is catatonia? Increased tone, I think. Psychomotor disorder that affects a personal ability to move in a normal way. Okay, so it is catatonia. Okay, so treatment, it is coming as a regular sessions, okay, which are performed on a twice a week basis. It is usually administered bilaterally. The electrodes are placed over the poles of the temporal lobes. It may be one more point which you can is that EEG waveform. Okay, so you can revise also EEG waveform, the normal EEG waveforms, the epilepticogenic epileptic waveform, and the basic purpose is that you don't give anesthetic agent which decrease the epileptic effect fits. Okay, because we have to induce, if you are using any medication which can attenuate the activity, then it will not be a good choice. That's why thiopentone is not a good choice. There was a medication which was available before, that is methoxytol, but it's not available now. And what about another medication? Can they be used? Ketamine and etomidate. What are the problems with it? Any comments?
Etomitate can cause adrenal suppression, and plus it is a strong metogenic.
They
Okay,
both reduces the seizure threshold.
reduces the seizure threshold. So should it be given? Should be it be a good activity or no?
In
So
this condition, it will be a good activity.
okay, so what it produces seizure where other agents have shown no seizure activity? Greater hemodynamic response, pain on induction, PONV, slower recovery, abnormal movements, adrenocortical suppression. So these are the disadvantages. On effect, duration longer than other agents, threshold may be reduced. And what about ketamine? Resurgence of use because it's being, do you know, ketamine is being used in a very low dose for actual treatment of depression. Okay. So ketamine is also you can one of the treatment strategies of depression. Now, I have like conducted some sessions for this procedure. May have an inherent antidepressant action. Emergence phenomena in increase intracranial pressure if you are giving in high dose, hypertension, low recovery. But actually, I am not sure what does the text say about it. But my suggestion that you can have a look practically what are the pros and cons, because actually propofol, why it is being used, because the induction and recovery is very smooth, predictable relatively, okay, and because usually these procedures are done as a day case, so you don't want anything which is causing more hangover. So maybe this is one of the reason, okay. So and of course this adrenocortical suppression is a bad thing, okay. uh, Another thing is that etomidate, this more associated with PONV and this abnormal movements which mimic like fits. So maybe this is the reason that etomidate is not being used. Okay, so next one.
There are certain drugs which increase seizure threshold, sir. This was question in IMM.
Okay, so what are those drugs?
I don't remember. I raising this point that this is important, and
Just Google it and tell us. Okay. So what are effects of ECT? Increase in intracranial pressure, increase regional cerebral blood flow, cerebral oxygen consumption, and glucose utilization, increase in blood-brain barrier permeability, headache, confusion, and transient memory loss are common in the immediate post-treatment period. Okay. So ECT may be given to patients with epilepsy, but treatment with anticonvulsants may increase the baseline seizure threshold, the anti-epileptics, resulting in higher energy requirements. ECT is itself an anticonvulsant. It has been used to treat status epilepticus. Okay, seizure thresholds are expected to rise through the course. Gradually, maybe more energy is required. So you should be knowing that it increases ICP, blood flow, increase oxygen consumption, and glucose like energy level, because more activity, so more energy is required. In cardiovascular system, we have discussed. Other effects: increase in intraocular pressure, intergastric pressure, nausea, myalgia, feeling of general ill ease, damage to crowns and bridges, implants. Okay, intraosseous denture, as I told you, that was one of the reason for giving this succinylcholine. Okay, so in like in any other pre-anesthetic evaluation, we have to do everything, but practically the thing is that there are some medication the patient is taking which have relevance with anesthesia. Like it, for example, if the patient is taking SSRIs or tricyclic antidepressants, if you want to give any this one hypotension, if you have phenylephrine and ephedrine, what would you like to choose? Ephedrine or phenylephrine? One person, please. Yes, Ali,
Yes, sir.
what would you like to give? Whether you would like to give ephedrine or phenylephrine?
Sorry,
The question is that if
sir,
such
sound bit
patient
disturbed.
who
Can you
are
please repeat the
on
question?
tricyclic antidepressants or SSRIs, okay, or MA inhibitors, which medication would you like to use if you have to choose between phenylephrine and ephedrine? Which medication would you like to choose and why?
Sir, I would like to choose the phenylephrine. I will try
Actually, your voice is
give
distorted. I will just
the medications which
your
and to prevent it.
Ali, I'm sorry, your voice cannot. So I think what you are saying is phenylephrine because it has direct effects, and ephedrine has both direct and indirect effect. And indirect effect is through the release of catecholamines, and actually these patients have high catecholamine levels. So it is not a good choice. It can have unpredictable effect and more effect, and it can cause even arrhythmia. That is one of the reasons. Okay. So these have some points about relative contraindication will be recent MI because actually, now these are the things on which they can make MCQ. So myocardial infarction within the last 3 months, CVA in the last 3 months, raised ICP or untreated cerebral aneurysm, it can rupture. Okay, unstable major fracture or cervical spine injury, pheochromocytoma. Okay, uncontrolled cardiac failure or severe valvular disease, deep DVT. What will happen in DVT? It can cause pulmonary embolism. Cochlear or brain implants pose technical challenges to the administration of ECT. This should be discussed with neurology team. Unilateral ECT has been achieved successfully in the presence of cochlear implants. So it's like that. So a few words about it, how to administer, we have discussed. Okay, so if you read like this, your output will be much more. So in this one question, we discuss so many things. Do you can say that the patient's having old age concerns and depression, and the patient is undergoing ECT. So we discuss about ECT. We have few words about some of supraventricular tachycardia. Actually, what is the treatment of SVT? Just a quick revision.
If
Vagal
it's
maneuver.
stable,
Vagal maneuver.
then
If
first we
patient
will
is
see, sir, is it stable or unstable?
very good, if it is unstable,
Then cardioversion, DC
cardiovert,
cardioversion,
synchronize cardioversion. Okay.
synchronize, DC
And
cardioversion.
synchronize cardioversion, we have to synchronize with what?
R wave,
If okay, so we have to synchronize. There is a system through which it will synchronize and it will deliver. So what else? If the patient is stable SVT, what you do?
vagal maneuvers
Like,
like Valsalva, ask patient to cough.
okay,
Carotid massage.
carotid massage. What is the problem with carotid massage if you do in old age? Yes, it there may be some clot and it may dislodge. Okay, so in old age it's a challenging thing. Don't do it both sides. It can cause problem. And what other options? Valsalva is that you can ask the patient to clench, you can ask the patient to cuff. So these are the Valsalva, or pressing the eyeball, okay, or placing ice on the forehead or ice on the eyes. Okay, so these are all vagal maneuvers. And then the drug of choice, which pharmacological medication you give for
Adenosine,
adenosine. How much
adenosine,
is the dose? How much is the
6
dose of
milligram.
adenosine?
Initially, we have
6
6
mg IV
milligram.
step followed by 12 mg.
Okay. How many doses? 6 milligram, 6 milligram, and then 12 milligram.
6, 6, 12.
Okay. And we have, because it metabolizes very quickly, so you have to give and flush. Okay. Fast. It has to be given fast. What are the problem with adenosine? It can cause bronchospasm. It can cause even asystole. Okay. Few
Transient
words.
systole, transient.
Yes. So, and I don't remember, but you should be knowing how adenosine work. Okay. How adenosine work. Adenosine mechanism. Can anyone know?
I think it blocks the potassium channel.
Potassium channel. Anyways, I don't remember it, but do have a look. Let's see if we can. It acts on the cardiac AV node, significantly slowing conduction. Okay.
And sir,
Okay,
before
let's.
giving it, we have to tell the patient that uh, your heart might get sync. So we have to tell all these patients.
Yes. Okay. So these are few things about it. Beta blocker can also be used, and we have to rule out the cause. SVTs, a number of time you have to rule out the cause as well. Anyways, so you are called to see a 65-year-old patient in the surgical ward, 3 days following an elective abdominal aortic aneurysm repair. Ali, can you hear me? Ali is here or no? Ali is not here. Anyways, just a second. Okay. So you are called to see a 65 in surgical following an elective abdominal aortic aneurysm repair. A thoracic epidural catheter is in situ. He is febrile and complains of back pain and lower limb weakness. So these are red flags. Okay. These are red flags: fever, backache, lower limb weakness, and neurological weakness. So red flag means there's something on which we need to immediately respond. Okay. So what are different options? Stop the epidural infusion and contact the neurosurgeon. Stop the epidural infusion, do regular neurological observations and monitor the epidural catheter site. Arrange an urgent MRI scan and inform the neurosurgeon. Stop the epidural infusion and start empirical antibiotics. Remove the epidural catheter and do a full neurological examination. So, what you see, we have to stop, we have to contact a neurosurgeon. Okay, but neurological observation and monitor this also we have to do. But the thing which will tell what's going on, I think the answer should be MRI. If I'm not wrong, let's see what is the answer. Okay, so the rest of the things will also be there. Okay, so what has happened? This one is epidural abscess. Okay, so it will have not only pain, fever, high WBC count, and you can do MRI. So there are many benefits of central neurological drug delivery. However, we need to balance the advantages against the risk of complications such as infection, nerve damage, and hematoma. Okay. NAB3 was on epidural. NAB is National Audit Project in UK. They just observe or monitor all the complication which occur in certain things. So different naps, one for anaphylaxis, awareness. So different naps have been done. You can it's right there in our this Google Drive link. Okay. So incidence of epidural abscess after CNB, central nerve block, is 2 in 100,000, 2.1. Although this is considerably low than previous studies, epidural abscess is still a very serious complication of central nervous block and can lead to permanent neurological damage. In the above scenario, the patient has sign symptom of established epidural abscess that needs decompression immediately. Okay, we should recognize patient at risk of spinal infection before commencing. So, what are those? Immunocompromised patients, patient with a local systemic infection, long-term vascular access, long duration of epidural catheterization, difficult central axial blot or a bloody patch after epidural, prolonged hospital stay, disruption of the spinal column, surgery or trauma. So, following epidural catheter insertion, catheter site checks, and regular temperature monitoring are very important to recognize epidural abscess. The classical presentation of epidural abscess is of pyrexia, back pain, and progressive abnormal neurology of the lower limb. Okay. However, in 1 in 4 patients have no backache. So absence of backache may not be there. So high suspicion, diagnose epidural, high index of suspicion is required to diagnose epidural abscess. Advice from neurosurgeon, neurologist, radiologist, and microbiologist are needed early in establish epidural abscess. So what they do, the most important action when we suspect is to organize MRI with gadolinium. It's a dye. Okay, this will help to decide whether open or percutaneous drainage should be used. Remember one thing that whenever the dye comes, you should be thinking about contrast-induced nephropathy. Okay, you should be thinking about anaphylaxis. So this should be in your mind whenever any discussion is coming like that. So you have to maintain the renal perfusion, and in any patient with risk, maybe you can consider of giving an acetylcysteine. Okay. In this example, arranging an MRI scan and in informing the neurosurgeon are the first and important steps to perform because early diagnosis and surgical decompression is needed. Although correct option is E, it is time consuming and delays the diagnosis. What is the E? Remove the epidural catheter and do a full neurological examination, but it will delay. I told you that everything has to be done. You have to remove, you have to inform the neurosurgeon, you have to start empirical antibiotics, you have to observe, but the thing which is aiding is epidural, is MRI. Okay. Even after surgery, only once muscle weakness is present, only 20% patients regain full function. So a full infection screen, including blood cultures, is mandatory. If an epidural abscess is suspected, at the same time, it is essential to remove the epidural catheter as well, stop the epidural infusion, and send the catheter tip for culture and sensitivity. Okay. As solely stopping the infusion is inadequate, option A, B, D are insufficient. The most common microorganism is Staphylococcus. Initial antibiotic therapy should be empirical and then modified depending on the culture and sensitivity results. While treatment must be guided by microbiological input, intravenous antibiotics are required initially for 2 to 4 weeks, followed by a prolonged course of oral antibiotics. Regular checking of inflammatory marker, back pain, and neurology should be used to monitor the response to antibiotics. A few more thing I just want to share about this, or I want to, this is another exercise for you. Whenever you have a patient at risk of sepsis or like any SIRS, you have to start on the line of sepsis. So because epidural abscess can lead to generalized sepsis as well, or generalized sepsis can lead to epidural abscess. So this is a vice versa. So you might need, if the patient has hemodynamic instability as well. So maybe you have to treat just like we treat any sepsis patient. So like ESR, CRP, cultures, and this lactate levels, fluid therapy. This thing all should be in your mind. Okay. And we have to remove the source of infection. So that is this one, epidural removal. So that is the things which you can just revise in your mind uh, in this MCQ. Just 2 seconds, please. Okay. Another thing which you should be revising is red flag for backache. Red flag, I will show you. Red flag for backache. So mm, 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 mm.
Yes, so there was a mnemonic for red flags, tuna fish,
Yes,
history of.
yes, very good. Do you remember some of them?
Sir, I remember fever, history of steroids, and
Yes.
cancer,
Yes. So
and
you see
thoracic.
older age, prolonged corticosteroids, severe trauma, presence of contusion and abrasion, multiple red flags. Uh, just a second. Red flag symptoms of backache, age under 18 or over above 50, anticoagulants use, fever, genitourinary issue, or this cauda equina. Okay, immunocompromised IV drug use, recent spinal surgery or epidural injection trauma. Okay, reduced anal sphincter tone. This is cauda equina syndrome. Hyperreflexia, lower extremity muscle weakness, saddle paresthesia, absence or decrease bulbocavernous reflex. This cauda equina. So cauda equina is the thing. So this is another revision tip which you have in this MCQ. Okay. Hmm. Okay, 70 kg, 36-year-old male for foot surgery under our regional anesthetic approach. Which of the following needles would you use to perform lateral popliteal nerve block? Actually, uh, this is a question with reference to the length. With the lateral approach, more bigger needle is used or anterior approach?
Sir,
Sir,
with lateral
basically,
approach, bigger needle would be needed, or posterior approach will also be done in 100 needle, and lateral would be with the 100 or 150 mm.
No, but actually the in anterior approach of sciatic nerve block, it needs longer needle. Okay. So short bevel peripheral nerve block needle 100 mm. When performing nerve block, the length of block needle is essential, considering long needles might have potential longer tissue damage if advanced further than needed, while the short needle may not be long enough to reach the nerve. So these are two things. So usually for interscalene, 25 mm, for cervical plexus or supraclavicular, 50 mm, axillary, femoral, popliteal posterior approach. When they are going posteriorly, it does not need a longer. Uh, that's what I was saying. Okay, so sciatic anterior approach is the longest. So for infraclavicular, paravertebral, lumbar plexus, sciatic posterior approach, and popliteal lateral approach, you need around 100 mm. Okay, so that is another thing. What about this cutting needle tip might be long bevel or short bevel? Long bevel needles are most likely to cause nerve damage by causing sharp nerve penetration. Okay. So although the nerve damage caused by short bevel needle is less frequent, the damage will be more severe. This is another thing. Okay. So with the bevel, they are telling this thing. So this is cutting short bevel. Okay. So bevel is this one. So cutting tip long bevel. Pencil point. So in pencil point, this is non-cutting. So cutting edge is like this. So this is the pencil point needles are believed to penetrate tissue rather than cut through it, thus providing an improved feel of anatomical layers through which they pass. It is not clear whether a pencil point needle or short bevel needle is safer to use. Most frequent needle used in current practice is short bevel one. Okay. It offers more resistance as it passes through the tissue planes, provides better tactile feedback than long bevel needles, and is less likely to cause nerve damage. Thus, in this clinical scenario, the most appropriate needle for a lateral approach is 100 mm short bevel. Okay, so actually, another thing is that there is no single strategy to avoid nerve injury. Okay, so usually when we give a nerve block, what are different ways by which we can reduce the chances? One is good anatomical landmark. number one. Then use of ultrasound to locate and then confirmation it with nerve stimulator. Number three. Then another thing, using of smaller syringes, because if you are using big 20 cc or 50 cc syringe, more pressure is required. So that the pressure will cause. And another thing is that there are special needles which have pressure transducers. So what is the number? How much? Because we don't use it, so it slips out of the mind. Anyone remember how much pressure should be? I think less than 15. Syringe pressure and injection pressure, how much it should be? Wajia, do you remember?
Sir, I just remember this thing that we check it with 10 cc syringe, that loss of resistance.
No, loss of resistance is something else. I hope you understand my question. Syringe,
Yes, sir. What sort of pressure if it
yeah, I think it is the number.
uh,
Let me check. The syringe pressure for peripheral nerve. Actually, there is pressure transducer. Okay, so I think it is, I think 15, if I'm not wrong, but I forgot the unit. What is the unit for it? You see, 15 psi. So I was correct. It is 15. I was just thinking whether it is PSIG or millimeter of mercury. So it is 15 PSI. Okay. So again,
okay, sir.
good anatomical landmark, because this question may be asked in talks and there may be some in MCQ as well, even in the Viva. Good anatomical landmarks, use of ultrasound to locate, then use of nerve stimulator to find the needle localization. Yes, another in plane approach, so that you are seeing the through and through passage of the needle. Then this one pressure, and using smaller size syringes. So these are the things which are important. Okay, so enough for today, I think, or one more MCQ. I just need a feedback from some of you. Is it good? Because, remember one thing, I again say the same thing. MCQs, if you are doing MCQs in a nice way, you can learn everything. But for that, you have to come out of this approach of where is the queen? Because usually when you are reading MCQs, you are only focusing what is the answer? What's the answer? What's the answer? So that is the least important thing. If you know the answer, okay, no problem. There is no guarantee that this question will come. If you don't know the right and left, why others? Why others? Okay. And another thing I will suggest you that you should be doing that, like if you are able to change the stem, okay, like you can change it with which needle will be for the which surgery for. So you should be knowing that what change you can do in the stem to change the answer, because this is a different sort of question. And another thing, remember one thing, this is the data they are telling you, okay, and this is the question they are asking you. So remember one thing, as here you see, most appropriate and the next step may be different. Okay, if they are saying immediate next step, maybe the answer will be stop the epidural and remove it. Okay, so maybe that is the answer. But if they are asking appropriate, so the answer will be changed. Okay, so thank you very much, and inshallah we will continue our discussion. Another thing I tell you, that like these Google Drive links, even I shared today in the group, any one of you is welcome to ask anything anytime. But I will tell you that make your brain work in this way. uh, Topic oriented study. Topic oriented study is the key to success, rather than you are reading a book and you don't know what are important points. It does not help. Okay, so thank you very much, and inshallah we will continue tomorrow. Bye bye.
Okay, thank you.